This
covering
conference
the
will now be recorded.
module, and I would be touching upon the important aspects or the important concepts that are needed for Urogyne module to ace the MRCOG Part 2 exam. So just to begin with, let's just start by looking at the resources or the study material that we would need to look at as we are studying for Part 2. All right. So as we all know, the major guideline that we need to know thoroughly for MRCOG Part 2 in Urogyne is the NICE guidelines on urinary incontinence and prolapse, right? We would also need to know management of bladder pain syndrome and post-hysterectomy vaginal wall prolapse, all right? There are a few TOG articles of importance which we may need to know, like particularly a few important ones like continence surgery at the time of pelvic organ prolapse. Nothing major there, but there are a few concepts that I would be touching upon today that you would need to know. Urogynecological problems in pregnancy, postpartum, urethral diverticulum, recurrent urinary tract infections, and certain talk articles. You may get one or two questions, one question possibly on urethral bulking agents in treatment of SUI. Okay, so let's get started. All right. So we will first cover the urinary incontinence and pelvic organ prolapse in women, the management part. All right. So I just want to know if you have read the guideline before coming for the class today. I just want to know if you are, I want to know how much you already know. I mean, if all of you who have joined the class have read the guideline. Have you read the guideline recently or even in the near past? Okay, all right, fine. We'll just proceed. Okay. So coming to the certain basic concepts, we need to touch upon the lower urinary tract symptoms for understanding what urinary incontinence is, okay, and what are the questions like, okay. This is taken from strategy and the RCOG e-learning that we have. So there are storage phase symptoms, voiding phase symptoms, as well as post-voiding phase symptoms, okay. We would also need to understand that the prevalence of women with at least one lower urinary tract symptoms ranges from 39 to 67%. So that's quite high, which is why this is such an important topic for us. Okay, so we would need to know what exactly these symptoms are and what is the importance of these symptoms. All right. So let's get started. The first one is storage symptoms. Okay, storage symptoms, voiding symptoms, and post-micturition symptoms. So basically, what I understand, what I am trying to tell you is what is important for us from the exam point of view is this first part here. This is the storage symptoms, this one. Okay, so what is storage symptoms? Basically, where we are looking at the capacity of the bladder to retain urine, right? So if the bladder capacity to retain urine is sufficient, things would go fine. However, if the bladder has any problem like that the detrusor is contracting too often, you would get symptoms like frequency. The woman may need to wake up in the night, that is nocturia, and sometimes may need to rush to the loo, that is urgency. All right. So we have when the detrusor, that is the bladder, gets active too often involuntarily, you can have bladder contracting resulting in frequency too often. Also urgency, that is the woman would need to rush to the loo. How is it described? That the lady needs to rush to the loo, that is urgency, and you would need to have you may get nocturia, a woman coming with nocturia, which is she needs to wake up in the night to pass urine. Again, all this is happening because the bladder is contracting too often, right? You can have urinary incontinence, which is also a storage symptom. You can get urinary incontinence because of this particular problem, that is bladder is contracting too often. Okay, so with a woman now rushes to the loo, but she cannot hold the urine because the detrusor is contracting to such an extent that she leaks. And what is it called? What is it called? Can I have a response in the chat box, please? What is it called? What is it? What is the symptom when the woman needs to rush to the loo and she leaks when she's rushing to the loo? What is it called? Anyone?
Urge incontinence.
Are we all on the same page? Are you sure about this? Is it urge incontinence? Somebody said hesitancy. What is hesitancy? Hesitancy is, you can see it's in the second column, so we would be coming to it. This is urge incontinence. See, remember, it's simple. Urgency is when you need to rush to the loo, right? When you cannot control. So it's urgency. You need to go. And when you need to go, you cannot control to such an extent that the bladder contracts. That is urge incontinence. That means the bladder contracts and you have leaking. That is urge incontinence, right? So remember, these would be your symptoms for storage. Okay. You would also have urinary incontinence related to stress, wherein the bladder, it may be because of the bladder neck hypermobility or the urethral mid-urethral support, but the bladder cannot contain urine with stress. Like when there is increase in abdominal pressure, coughing, straining, there is leakage. That is stress urinary incontinence. Are we clear on this concept? Okay, so storage symptoms is when the detrusor is contracting excessively, or when there is urinary incontinence because the bladder cannot hold urine when there is excessive pressure. That is stress urinary incontinence. So you have frequency, urgency, nocturia, which happen because the bladder is contracting too often. If it is severe, you may also get incontinence, that is urge incontinence. Okay. And the other thing is stress urinary incontinence, which happens with increased abdominal pressure. Is that clear, Dr. Preeti? Am I clear?
Yes, ma'am.
Please message in the chat box. Yes. Okay. So we have your storage symptoms here. Now we have voiding symptoms. Now voiding symptoms is related to the stream of urine. And that can happen because of problems related to the urethra. Okay, so sometimes when there is bladder outlet obstruction, you may have slow stream. Okay, now this is the outlet problem, not really the detrusor problem. The outlet problem may be slow stream, maybe because of some stricture in the urethra. Okay, there may be intermittent stream, which may also be because of an obstruction. Hesitancy, that means she wants to pass urine, but she cannot initiate. That is hesitancy. That can happen if there is kinking on the urethra. Okay, so there is, you have the bladder, okay, and you have the urethra, right? So if this urethra kinks because of whatever problem, the bladder is falling out, say, and the urethra is kinking. Okay, so a condition like a cystocele. There you may have hesitancy. That is, the urine, the woman is not able to pass urine because simply because there is kinking of the urethra. Okay, so usually this is voiding symptom, hesitancy, right? She may need to strain to pass urine. Maybe there is kinking, maybe there is obstruction. She needs to strain. That is also avoiding symptom. And there may be terminal dribbling, okay, which is the most common voiding symptom. Remember that. Okay, terminal dribbling, it could be because of a urethral diverticulum or something like that. Terminal dribbling is when the flow is fine, but later when she stops, voluntarily stops, there is some little bit of dribbling that is happening. Okay, that is again a voiding symptom, right? So then there is the post-micturition phase. That is, she has completed the act of voiding, and now there are some symptoms happening. Okay, she may feel that the bladder is incompletely emptied. Again, that is the most common one. Again, it can happen when there is kinking like this. Okay, so that is a post-micturition symptom. Then, and most common here is incomplete sensation of emptying. Okay, or there could be a post-micturition dribble, like in case of a urethral diverticulum. All right, am I clear? What we need to concentrate on is this for the exam. Okay, so bladder contracts excessively. Remember, the manifestation of that could be frequency, urgency, nocturia, urge incontinence. And when there is increased abdominal pressure, the bladder cannot contain urine. With the increased abdominal pressure, because of whatever reason, maybe the hypermobility or the mid-urethral support, then there is incontinence, that is stress urinary incontinence. These two important concepts have to be clear. Am I clear with this? Yeah? Can I proceed further? Because I need you all to understand this in order to be able to understand the rest. Yeah? Am I clear so far? All right. There is no response, but I think I will proceed to the next slide. All right. So this is just to sum up what we've just discussed. Lower urinary tract symptoms would be storage, voiding, and post-maturation symptoms, and it affects around 39 to 67% of the population. And this points are taken from RCOG e-learning, and which is important and which may be asked in the exam. And storage symptoms, as I mentioned earlier, clearly that storage symptoms are the commonest symptoms. The prevalence increases with age. SUI is the most common form of urinary incontinence. Remember that. Almost 30% of all urinary incontinence would be SUI. Okay? SUI is almost 30% of urinary incontinence. All right? Then, mixed urinary incontinence and urge incontinence are more prevalent in the elderly. Okay, possibly because of estrogen deficiency, right? So in the menopausal age group, of course, even SUI is more common in the elderly. But what is, if you see the number of women that would have urge incontinence, the larger proportion of those would be the elderly women. Okay, SUI can happen even after deliveries, even in younger women. All right. So, overactive bladder is a symptom complex characterized by presence of urgency, but may also include, as we have already seen, frequency, nocturia, urge leakage. You must understand that OAB is basically because of detrusor overactivity. Okay, so because of the overactivity of the detrusor, usually OAB is because of a detrusor overactivity. Okay, it may be because of other reasons like UTI as well, but when you have these symptoms, when UTI is ruled out, it is detrusor overactivity more commonly. Now, what is the difference between OAB and detrusor overactivity? This is important because you can get questions in the exam, wherein you may have to choose from OAB and detrusor overactivity and all those options, and you would get confused when both the options are there in the scenario which is mentioned. OAB is the symptom complex, all right, and when it is detrusor overactivity, when it is proven on anybody, what is detrusor overactivity?
Urodynamically proven.
Yes. So when you have urodynamic studies that show objectively that there is increase in the contractility of the bladder, that is detrusor overactivity. Okay. While overactive bladder is the symptom complex, is that when she presents to you with overactive bladder symptoms like urgency, frequency, nocturia, urge incontinence, that is overactive bladder. So if there is a clinical situation in the exam wherein it is mentioned to you that this patient has come to you, a 60-year-old lady has come with symptoms of urgency, frequency, and she leaks sometimes while she's rushing to the loo, UTI is ruled out. What is the diagnosis? And in the options, if you find there is OAB, there is SUI, there is detrusor overactivity, and other options, you will choose OAB if urodynamics is not done. Is that very clear? Okay. So if it is not mentioned, you will choose OAB. All right. Now, so basically, urinary incontinence is as defined is by the International Continence Society is the complaint of any involuntary leakage of urine. Any involuntary leakage of urine. It is usually of two types. That is urge incontinence and your SUI. SUI is where there is increase in abdominal pressure because of exertion or sneezing or coughing that can result in leakage. Mixed urinary incontinence is when the lady has symptoms suggestive of OAB, that is urgency, frequency, your nocturia, and urge incontinence. And at the same time, the lady has symptoms suggestive of SUI as well. All right, that is, she also leaks while sneezing and coughing. Then it is mixed urinary incontinence. Okay, OAB can be wet and dry. That means she has urgency. She rushes to the loo, but every time she reaches the loo on time and then she voids. Or she rushes to the loo, and while she's rushing to the loo, she leaks. That is OAB wet. And if she doesn't leak, that is OAB dry. So if there are only symptoms of urgency, frequency, nocturia, it is OAB dry. But if it is associated with leakage, it is OAB wet. Clear so far? Any doubts so far? I would want to know, because this is the basics that we need to understand when we solve questions. Right? Everyone clear? Okay, fine. Now coming to history. Again, the first thing that we need to do when we have a lady coming with symptoms of incontinence, the first step, they may ask you this question, and it is important to note what exactly is the question asked. Okay, the question may say the first, sorry, okay, yeah. So they may say the, one second. Okay, the question asked may be the first step that you need to take when you have a case of incontinence or a patient presents with incontinence. The first step is to categorize. Okay, first step is to categorize. Yeah, the second step we will be seeing in a bit, but remember the first step is to categorize. Okay, and when there is mixed urinary incontinence, remember you first need to start her on treatment with and direct the treatment towards the predominant symptom. Of course, if there is mixed urinary incontinence like SUI and urge incontinence coexist, you will definitely tell her about the initial conservative measures for both the modalities, I mean both the problems, and you need to direct the treatment towards the predominant symptom. Do not think because the NICE guidelines mentions that if there is urge predominant mixed urinary incontinence, you would do urodynamics. You would do urodynamics first. No, that's not true. You would start her on conservative measures first. Urodynamics is done before surgery. Okay? Have that clearly fixed in your mind that urodynamics is done after you have tried out your initial conservative measures, right? So the first step here, in this case, when the patient comes to you with incontinence, is to know what type of incontinence it is. Even in our part 3, for part 3 candidates, that's what we tell them. And when there is a history given by the role player that I have so and so a leakage and all that history, the first thing that you need to understand is whether it is SUI or it is OAB or it is mixed. Important. All right. Now, the management depends on what type it is. If it is SUI, you will do SUI management. If it is OAB, you will do OAB management. If it is mixed, of course, you will direct the treatment towards the predominant symptoms, but you will also not ignore the other incontinence symptom that she has. Okay, so both the conservative measures you would be starting. Now, the next step is to do a physical examination. Okay, you need to assess, as the NICE guidelines mentions, that you need to assess the pelvic floor muscle contraction before using supervised pelvic floor muscle training. The patient may not be able to contract her muscles at all. Okay, she may be having a nerve problem, or she may be just having atrophy of the muscle. Okay, patient may not be you can talk to her about pelvic floor muscle training, but she may not respond to your pelvic floor muscle training. So for prognosis, you need to know whether the tone of the muscle is good. Okay, so for physical examination would be the next step that you would do. Okay, so first is history, know what type of incontinence it is. Then second step is physical examination to understand whether she is a good candidate for PFMT or not. Okay, that is when you're checking, particularly so when you're going to treat her for SUR. Okay, the next step or the first investigation. Okay, this is history examination. The first investigation that we do in any urinary incontinence is urine testing. Clear? The first investigation, and this is not culture. What do? The first thing that you do is urine dipstick for leukocytes and nitrites. Very good. You do urine dipstick. See, I need you to be active. If you're feeling shy to unmute yourself and answer, you could just message in the chat box. It's okay if you make mistakes. It's fine. You will remember these mistakes. All right. So you can just message in the chat box, and that way it would be more interactive, right? So you remember the first step is to know what type of incontinence. The next step is to examine her and check her pelvic floor muscle tone. The third step is to do a urinary examination. Is that very clear? Yeah. So we can proceed further. Yeah. So yeah, this is the next thing. This is important for us to know because you get questions here. You get SBAs on this particular chart. Okay. So the first thing, if the patient we'll see the first column. If the patient comes with symptoms suggestive of UTI, say she's come with pain, she's come with burning micturition, even frequency for that matter is considered as UTI symptom. Okay, you do a urine dipstick. You can either have a positive report for both leukocytes and nitrites, or you can have negative for either or both. Both may be negative or one may be negative. Okay. Now, if you have positive test for leukocytes and nitrites, what do? You would send, and she has UTI symptoms. So she has UTI symptoms and she is positive for leukocytes and nitrites. In that case, you would send her midstream urine for culture sensitivity. And once you have sent the urine for culture sensitivity, it takes time, right, to come the report to come. So you would start her on antibiotics pending results. Okay, so you send her urine sample for culture sensitivity and then start antibiotics. You don't want to start antibiotics and then send urine for culture sensitivity, because the antibiotic that you give may sterilize the urine and then you will not get any bacteria growing. So you need to send the urine for culture sensitivity and then start her on antibiotics pending the results. Okay, so that is if UTI. This is simple to understand. If there are UTI symptoms and she also has objective test suggestive of UTI, that is, she's positive for leukocytes and nitrites. Okay, but in case she's negative for either, okay, again she has symptoms. When she has symptoms, and symptoms is given more weightage, in this case, because there are symptoms, she may be negative for leukocytes or nitrites, either of them. Okay, here you will send her midstream urine, but you will consider antibiotics. Okay, because we know that UTI symptoms are to be treated seriously. Okay, so if there are UTI symptoms, you would in most situations you would give antibiotics. The difference here is If there are UTI symptoms and if she's still having, and she's having leukocytes nitrites positive, you would give her antibiotics for sure. But if there are UTI symptoms but she's negative for either, the word used is consider antibiotics. So you may get such options, maybe in the form of EMQs or SBAs more commonly. So you may get such options. So these are consider antibiotics. Why consider? Because they are not positive for leukocytes and nitrites both. They are negative for either. Okay. Now, if there are no UTI symptoms at all and she's just come with urinary incontinence. Okay, remember we are evaluating a lady with urinary incontinence. Okay, now she just come with urinary incontinence, but there are no symptoms suggestive of UTI as such. Like there is no burning micturition, there is no hematuria, there is no pain, there is no, say, no frequency as such. Then what do? You would send midstream urine for culture sensitivity if the leukocytes and nitrites are positive. Okay, but you will not start antibiotics because she's not symptomatic. Okay, so remember, symptoms, antibiotics. One is definitely offer, the other thing is consider. Okay, no UTI symptoms, need not start antibiotics. Okay, but if she is positive for leukocytes and nitrites, you would send midstream urine for culture sensitivity. That is for sure. Okay, and if there are no symptoms of UTI and the urine dipstick that she has done is negative for either leukocytes or nitrites, you need not consider it to be UTI at all, and you need not send her midstream urine for culture at all. Is this very clear to everyone? Because I have a question. Okay, so I have a question that a 60-year-old lady comes to you with symptoms suggestive of, say, leakage on lifting weights, okay, and no other symptoms, no other urinary symptoms. What would you do in this case? What is the first investigation that you would do? Come on, just reply in the chat box. First investigation, quickly. Hello. Okay, fine. Yes, very good. So what I was looking for is, okay, Anam, can you please tell me why midstream urine? Why midstream urine? Mhm. Midstream urine is basically, see, when you say MSU, sorry, okay, all right. So MSU is the midstream of the urine that is collected in a sterile bottle. It is to be collected in the sterile bottle for culture to know what bacteria are growing. Okay, so it is to be collected for culture sensitivity. Okay, now I've told you that this patient has come for with symptoms suggestive of urinary leakage on coughing, okay, on straining. No other symptoms. What is the next step? Is it going to be midstream urine or is it going to be anything else? Dr. Anna, I hope I'm pronouncing your name properly. Yes? What would it be? Quickly. Quickly. It would be? It would be? Yeah, most of you have answered correctly. It would be a dipstick. Right? What is dipstick? You just dip into the urine with it is a test. It's a dipstick test to check whether on the dipstick it shows positive for leukocytes and nitrites. Okay, so that's the first step, as we have seen, right? Midstream urine is sent if when would you send? In this case, would you send midstream urine for culture? Say it is positive for both leukocytes and nitrites. What would you do? What would you do? Dr. Anam, can you please elaborate? What exactly is the question?
Yeah, doctor, I get the point. You mean the dipstick just in case as outpatient. If there is any positivity, then we'll send for midstream urine because they want to avoid contamination for culture. That's what I get.
It's not contamination for culture. It is for you to understand what microorganism is growing in the urine. That's so
Yeah,
for you to treat it accordingly.
yeah.
Okay. So basically, you would check on the urine. You will ask her to collect urine in a bulb, and you will take that urine. You will put that dipstick in the urine and check whether it's coming positive for leukocytes and nitrates. That's the first step. Now, based on the report of leukocytes and nitrites and symptoms, you would then take the next step. Now, in this symptoms, the symptoms that I explained to you, which category does she fall into? UTI symptoms or no UTI symptoms? Quickly, what is the category? Quickly, we have to cover a lot. The entire guideline would be covered. So you can tell me quickly, what is the category? UTI, does it fall into UTI symptoms or does it not fall into UTI symptoms? She has urinary incontinence with straining.
No UTI symptoms.
Great. Very good. So she doesn't have UTI symptoms. UTI symptoms would be burning micturition, maybe frequency, or it would be hematuria. Okay. So these are considered as symptoms suggestive of UTI. Okay. OAB symptoms are mostly similar to UTI symptoms. So when there are OAB symptoms, you can consider them as UTI symptoms. Like she needs to rush to the loo, she has burning micturition, particularly burning micturition. Okay. But if she's simply leaking on straining, that is simple, pure SUI, that is not considered as UTI symptom. Got it? So if it is not UTI symptom, then you can just, what was the next step? So if she is positive for both leukocytes and nitrites, what are you going to do? Quickly, 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 quickly.
Send for culture
Will you start antibiotics?
if she has symptoms.
Yeah, but in this case, would you start antibiotics? This is an
No,
important
ma'am.
concept. Huh? So this is it. Yes, very good. You send midstream urine, no antibiotics. Okay? Because, I mean, no antibiotics now. If the midstream urine culture is growing something, you will consider antibiotics later to treat her. But right now, you are not thinking of SUI because she doesn't, I mean, sorry, you're not thinking of UTI because she doesn't have UTI symptoms, although she's positive for leukocytes and nitrites. Okay? You are sending her urine culture only because she's positive for leukocytes and nitrites. The next column. The next column says that she is okay. Suppose that that urine that you tested initially was positive for leukocytes, negative for nitrites. What would you do now? What would you do? Quickly.
Send culture. Send culture.
Mm, why? Why?
If either leukocytes or nitrates are positive, we have to send, no, ma'am.
No. What did I say earlier? What is this column here? Can you see this? What is this? What is this? Sorry. Can we go back to okay. What is this? Can you see that?
Ma'am, but in the yes, ma'am, but in the middle one is written positive for leukocytes and nitrites. Leukocytes
No, no,
for
no, no, no,
nitrites.
no. Here it is. This is, I would say, let me just change this because, you know what? This has cut it out, okay? Because I think it was supposed to be here and it has come here. Okay, let's cut this out. This and this is not there. Okay.
Okay.
So it is negative for either leukocytes or nitrites. The leukocytes and or nitrites is supposed to be in the fourth, in the third column. Okay. See, when you say negative for either, that means one of them could be positive, isn't it?
Yes.
Right? When you say either, one of them could be positive. So if one of them is positive, it is like as good as negative.
Okay.
Okay. So in that case, you do not, it has to be positive for both for you to send urine culture in case there are no symptoms of UTI. Is that clear? Okay. Everyone clear?
Okay. Yes.
Any doubts? Any doubts, please? Is this clear? Okay. So basically, if there are no symptoms, no UTI symptoms, you would check for positivity for leukocytes and nitrites. If leukocytes and nitrites are positive, you would send culture, wait, and then antibiotics if the culture is growing. If not growing, no antibiotics. If there are no UTI symptoms and she's negative for either, one of them is negative or one is positive, you don't need to do anything. Okay? And if there are UTI symptoms, you will definitely send midstream urine for culture. No doubt about that. Okay? You will prescribe antibiotics on the day that you're sending the urine for culture in case they are positive for leukocytes and nitrites and she has UTI symptoms. But if she doesn't have nitrites or leukocytes, you can still consider antibiotics, but it's okay even if you wait and start antibiotics for UTI, depending on the culture. Okay, so this chart has to be thoroughly done. All right. Now, the next thing is examination. Okay, examination and investigation. Okay, if you have doubts and still it's not clear, write it down. Okay, write it down, and then we can discuss it on the group. All right. If there are any doubts, you could just please just write it down, and I will be happy to discuss and answer on the group. Now, next is investigations further. We did one investigation that we did was urine. We checked the urine dipstick. Depending on the dipstick report, we checked whether the culture is needed or not. Now, the next investigation that we would need to do is residual urine. Okay. Now, again, do you do it in all cases? Residual urine? Do you do in all cases?
No, ma'am.
Okay. So, which cases do you do residual urine?
Stress incontinence.
Stress
If
incontinence.
there,
Why?
Like
Why?
if we go for surgery, it would make it more worse.
Okay. Okay.
in
But what
recurrent
does the
UTI,
guideline say?
recurrent UTI
Right.
and voiding
See,
dysfunction like hesitancy, intermittency, and
correct,
those.
correct, correct. So basically, as per the guidelines, yes, maybe in routine practice, to be on the safer side, maybe you would be doing residual urine in your day-to-day practice in SUI because you're worried it is actually just SUI or there is some bladder problem and she's leaking the blood because the bladder is feeling is not getting emptied efficiently. Okay, so but as per the guideline, when do you do your residual urine is if she has symptoms of voiding dysfunction. That means, what is voiding dysfunction? The second column. Remember the second column. It is when there is any
Hesitancy.
hesitancy. That means there is some obstruction there. Okay, when there is poor stream, there is some obstruction, something wrong happening. That is when you're likely to have increased urine back in the bladder because the bladder is not getting emptied because there is post um, some distal problem in the urethra, possibly, right? So that is why she has voiding dysfunction. So bladder is not getting emptied. Or when there is recurrent UTI. Why? Because again, recurrent UTI may mean that the bladder is not getting emptied effectively, and that is why there is recurrent UTI. Okay, the bladder is having, say, hypotonia. Bladder is not emptying. There is stasis of urine that predisposes to UTI. Okay, so these two cases, when there is hesitancy or any of those poor stream, terminal dribbling, any of these symptoms, terminal dribbling, okay, common symptoms. So you may get in the exam. This is voiding symptom. So any voiding dysfunction is there, you need to check the residual urine. Or when there is recurrent UTI, you are worried whether there is stasis of urine and that is why she's getting recurrent UTI. That is when you need to check residual urine. And what is abnormal? This is important again. More than 100 ml is abnormal. Is that clear? More than 100 ml is abnormal. Okay, that means she has, what is more than 100 ml? She has passed urine. You ask the lady to pass urine, and then with an ultrasound, you check amount of urine in the bladder that is remaining. Say if she's passed urine already, she's come back to you, and then you do an ultrasound and you see that the urine volume is 200 ml. That means her bladder is not emptying efficiently. That means there is increased volume in the bladder even after voiding. So that is significant. Okay. So you would prefer to do a bladder scan rather than, you can even know whether there is residual urine by passing a catheter and seeing amount of the urine that is flowing out. Okay, but that is invasive. You can introduce infection. So you don't want to do that. That is uncomfortable for the patient. So rather, what is preferred is bladder scan, ultrasound. Okay, so this is about your residual urine. So the first, again to revise, the first thing that you do when the patient comes to you with urinary incontinence is to categorize the urinary incontinence by history. The second thing you do is you examine for the pelvic floor muscle tone. The third thing you do is urine dipstick. Okay, and based on the urine dipstick, you do midstream urine for culture. Midstream urine for culture is not done as the first step. First step is urine dipstick and then midstream urine for culture. Okay, and then the next thing that you do is your residual volume. Not in all cases. Not in all cases. It is done only when there is urinary voiding dysfunction or recurrent UTI. Also, what you need to do is symptom scoring and quality of life assessment, which is more important for MRCOG part 3. Okay. Now, this is college favorite question. What is it? Bladder diary. Okay, so it is used in initial assessment of women with urinary incontinence, particularly overactive bladder. Okay, so both the incontinence, you will definitely use bladder diary. Okay, you need to tell them to maintain a 3-day bladder diary. That means, what is bladder diary? It is just a documentation of the amount of fluid that she has, the number of times that she goes to the loo, the number of episodes of leaking that she has, the number of times she wakes in the night. So it is documented for you by the patient, because sometimes the patient may forget, patient may not be able to express well. So when the patient has it documented for 3 days and you review it, you know exactly what category she belongs to. Okay, so that is the importance of bladder diaries. So the next thing that you do, so the patient comes to you in your clinic, the first, you take a good history, you examine her, you do a urine dipstick. Based on that, you check her midstream urine. You can even do her ultrasound for residual urine, depending on what symptoms she has. And then you tell her, maintain a bladder diary. All right, is that very clear so far? Okay, so let's revise. The first thing, what would you do? Let me, okay, right. First thing is symptoms suggestive of urinary incontinence. The first thing is to categorize. Very important, right? Once you have categorized, the next thing is digital examination for pelvic floor muscle contraction, investigate urine dipstick, bladder diary, and residual urine only in these cases. This chart is important. You can get an SPA in any of these. All right. Then next, coming to, yeah, so this is basically the explanation for bladder diary, what exactly is to be documented in the bladder diary. Okay, I've already told you. Urodynamics. Now, urodynamics, when is it done? Very, very, very important question. If the patient comes to you with, say, symptoms suggestive of urinary incontinence with straining, and now she has tried PFMT and all other measures, all those measures have failed, and now she's come to you for surgery. What would you do urodynamics? Yes or no? I want the answer in the chat box. Yes or no? Quick, 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 quick. No one is answering. Would you do a urodynamic test or no? Scenario is given to you. Patient has stress urinary incontinence. She has tried PFMT and she's now, there is no improvement, and now she wants surgery. She's done all the other conservative measures. She's not obese and not a smoker, nothing. Okay. She's done all the conservative measures. She's exhausted all the measures. Would you do, she wants surgery, so would you do urodynamics or not? Quick, 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 quick. Very good. Excellent. No, you would not do urodynamics because as per the guidelines, no matter what the routine practice is, as per NICE guidelines, before pure SUI, what is pure SUI? That means there is no mixed symptoms of urgent incontinence or urgency, overactive bladder symptoms are not there. That is pure SUI. So you will not do urodynamics before surgery for pure SUI. Very clear. Okay. Now, if you are contemplating doing surgery for a patient who has overactive bladder symptoms, on the other hand, the surgery for overactive bladder is basically going to be intravesical botulinum, which we will be seeing later. But if that is the case, you will always do urodynamics. So, SUI requiring your surgery, okay, SUI for surgery, you do not do urodynamics. On the other hand, if OAB is for surgery, you would do urodynamics. Before putting botulinum in the bladder, you would do urodynamics. Is that clear? Okay, this is the first point that I want you to understand. The second thing is the other indications that are mentioned in NICE guidelines. Before surgery for SUI, now this is before surgery for SUI, you would do urodynamics only if, see, pure SUI, you're not doing urodynamics. But if it is urge predominant mixed urinary incontinence, or where the type is not clear, and now you're contemplating doing a surgery for SUI, okay, you would do a urodynamics because you want to know whether it is actually SUI or is it OAB symptoms masquerading as SUI. That means sometimes what happens is a patient may actually have a detrusor overactivity, okay, and then she coughs, she leaks. It may not actually be because of the SUI, it may just be the detrusor overactivity, and she's just presenting to you that I cough and I leak, okay, and she's also having urgency frequency. That means she's actually maybe just detrusor overactivity, and you put a mid-urethral sling for her. That detrusor overactivity is going to continue, and she may get complications because of that. So that is why when there is mixed incontinence, type is not clear, and urge predominant mixed urinary incontinence, you would do a urodynamic study. Okay, when you are doing surgery for SUI. When there are symptoms suggestive of voiding dysfunction, okay, like you have kinking on the urethra and there is, say, hesitancy, or all of those voiding dysfunction symptoms, hesitancy, your poor stream and terminal dribbling and all those problems that you have before, and the SUI symptom may be there, and you may be thinking of doing a surgery for SUI, you first need to understand whether it is It is actually SUI, or is there any other problem that is there? So you need to, because there is voiding dysfunction. Voiding dysfunction is not related to the bladder contraction, or it is not related to storage symptom. So that is why you need to do urodynamics. Okay. Anterior apical prolapse with SUI. Okay. You would still need to do urodynamics, because again, you want to be very sure before doing an SUI surgery for a problem that is existing not just in the bladder, it is the entire anterior vaginal wall. You want to be very sure whether it is SUI purely, or if there are any other bladder abnormality like your overactive or a diffuser overactivity. Because if there is diffuser overactivity and you treat her for SUI, that mid-urethral string or Birch-Kolper suspension is not going to affect the way the diffuser is contracting. That is why it will continue to contract, and your SUI surgery is not going to help. Okay, so when there is anterior or apical prolapse, when there is a bigger problem in the anterior compartment, okay, you cannot be very sure that this is just pure SUI. Sometimes when you just treat the anterior wall prolapse, it can even treat your SUI. Okay, so you need to be very sure whether it is actually SUI, right? And when there is history of previous surgery for SUI, that means you have tried a surgery before for pure SUI and that has not worked. And now this time she's come back with SUI. You need to do a urodynamics to be very sure that it is indeed SUI. All right, so that is what these are the before surgery for SUI. What is the word that is important here? Before surgery for SUI, you would do in these 4 cases urodynamics. Before pure SUI, that means there is only leakage with straining. You will not do urodynamics. Before OAB, you will always do urodynamics. Before treating for OAB, that means I am thinking of doing intravesical botulinum. You will always do urodynamics. Is this very clear? Clear? Everyone? All right. I hope that Y means yes, Dr. Anam. Yes? Or is it a Y?
Yes, doctor.
All right. All right. Thank you. Urodynamics. Okay. I think urodynamics would be, wait. Okay. Fine. So now you need to understand a little bit about urodynamics. Also, there is a talk on urodynamics, which we would be briefly discussing. Now here, okay. So can you see there is a probe going into the bladder. There is a probe going into the rectum. Okay, in the vagina, and there is a probe going into the bladder. Can you see this? Okay, and the bladder is being filled. Okay, now what happens is this: the probe that is going into the bladder will actually tell you the P. It's in the bladder, so it's P vesicle. Clear? Now, the probe that is in the vagina will tell you P abdomen. This is clear so far? Come on. Clear? Okay, fine. Thank you. So, if it is bladder, pressure is the P-Base detected by the probe in the bladder. Pressure in the abdomen is P-Abd detected by the probe in the vagina. Okay. What we want to know really is what is the pressure that is only exerted by the bladder, by excluding the pressure exerted on the bladder by the abdominal cavity. That would be P det. P det is the pressure only exerted by the detrusor. But when we put a probe in the bladder, we are not only detecting the detrusor pressure, we are also detecting, because the bladder is in the abdomen, we are also detecting the pressure in the abdomen. So basically your P Vs that you're detecting here, your P Vs is P ebbed plus P detrusor. Because the bladder is in the abdomen, the vesical pressure detected is the sum of abdominal pressure and detrusor pressure. Detrusor is because the detrusor contraction is happening. So when the detrusor contracts, it builds pressure. That pressure is called P det. While P ebbed is the pressure because the bladder is in the abdomen. So the abdomen is also putting pressure on the bladder. Okay. So how we calculate P det is by subtracting the abdominal component from the vesical component. Is this very clear? Very clear? Dr. Anam, I want to see your why. What about the others? Dr. Preeti is here. Dr. Lay, Dr. Seema. Come on. No response. Am I not clear? Okay, thank you so much. Fine. Okay, so this is your concept of P Ves, P ebbed, and P det. Now, so what happens in SUI? What happens in SUI is you have your abdominal pressure rising. I mean, when you cough, your abdominal pressure will obviously rise. Okay? PVAS will rise because the poor bladder is in the abdomen. So what happens? When the abdominal pressure is rising and the vesical pressure is rising, you will have leaking. If the bladder, the continence system of the bladder is not intact, she will leak. Otherwise, if the continence system is intact, that means the bladder neck problem is not there and the mid-urethral support is fine, she will not leak even if she strains or coughs or does Valsalva, whatever that is. Okay, but when she coughs, P abd will rise and P vesicle is obviously rising and there is leaking. That is as simple as this. With abdominal pressure, if there is leaking or not leaking, that is what you need to see on urodynamics. Okay. What happens in OAB? Can someone tell me? What happens in OAB? Quickly. Yes. So in OAB, you will have your P det increasing while the bladder is being filled. Okay, P det obviously will increase when the bladder is full and you want to void. And you void. Then the P detrusor will increase. But there should not be increase in P det beyond 15 centimeters in the filling time. Okay. However, if that happens, that means there is OAB. So what you need to check in your urodynamic chart, you check if in the filling phase there is any elevation of detrusor pressure more than 15 centimeters. Earlier it is, I mean, when the bladder volume is not much, it is 10 centimeter and more than 300, it is 15 centimeter. So you just check if that spike in the detrusor pressure is happening. If that is not happening, P det is fine. Your DO is out. Okay. And when you need to check for SUI, you need to just check if there is any leak with SUI, with abdominal pressure rising. Okay. In detrusor overactivity, you may or may not have leak. Okay. And this is what I was telling you. about the difference between OAB and detrusor overactivity. Detrusor is overactivity is the diagnosis established after urodynamics. Okay, here. And OAB is the diagnosis based on symptoms, while SUI is diagnosis based on symptoms, and it's called urodynamic SUI when it is established on urodynamics that it is actually SUI. Clear? Yeah. Okay, so going to the next one. Okay, so this is urodynamic stress incontinence. We'll see this later as well. All right. Now there is this question that may come for you in the exam about local multidisciplinary team and regional multidisciplinary. There are two types of MDTs that deal with problems of incontinence or urinary low urinary tract symptoms. Okay. The first one is the local MDT. Okay. So the local MDT is the MDT that would review any invasive procedure which is done for primary SUI or overactive bladder or primary prolapse. Anything primary. What does that mean? She's come to you for the first time with symptoms suggestive of SUI. No, not associated with, say, wall prolapse and this prolapse, that prolapse. It is simple SUI, simple overactive bladder, or she is simple prolapse. And you want to treat her surgically. You will go to local MDT. Any surgical intervention or any invasive procedure for SUI, overactive bladder, primary prolapse is a local MDT. Now, if the proposed management for women with primary SUI or overactive bladder or primary prolapse requires input from a wider range of healthcare professionals. Let me give you an example. If there is, say, obesity, that has to be, she needs to shed weight and she's, say, BMI 40 and she's come to you with SUI. You would need to involve the dietitian, the physiotherapist, and all those, other, maybe the bariatric team and all those people. So there, in that case, when you need input from other healthcare professionals, you will go, and it is pure SUI. The surgically, it is same as this first point. Then you would go to local MDT. Okay, so this is where your local MDT comes in play. Now, when do you need regional MDT? Regional MDT deals with complex pelvic floor dysfunction and mesh related problems. Remember that. Okay, so complex problems. So you have already done a continence surgery and now she's come back with continence. That is, she requires a repeat continence surgery. Okay, when she requires a repeat surgery, if you're managing the repeat continence with lifestyle and conservative measures, you need not always refer to regional MDT. But when she requires a surgery for the repeat incontinence, then yes, then MDT, regional MDT. If they are having repeat same side prolapse surgery, I'd put a question in the group. If it's a new site, say she was earlier treated for anterior wall prolapse with anterior colporrhaphy, and now she comes with a posterior prolapse, that is a rectocele. What would you do? Which team would you send her to? Local MDT or regional MDT? Quickly. Local or regional? Come on. Yes. So if it is a different site of prolapse, that means it's a different area altogether, right? So you can just go to the local MDT. But if it is the same site prolapse, that means you're operating in the same scarred area where you have already operated. Then it is regional MDT. Then, if the preferred treatment option is not available in the referring hospital, you need to send her to the regional MDT, because then they will see where that particular option would be made available to her. If there are coexisting bowel problems that may need colorectal intervention, then look, regional MDT. So complex problems basically. When there is vaginal mesh for prolapse, is one of the treatment options for them. Like they know the problems with mesh complications and they want to have a vaginal mesh, then it is it is one of the treatment options. You can consult the regional MDT, or when they have a mesh complication. Okay, and most importantly, when they are considering surgery and wish to have children in the future. This may come as one of the questions, the last point. So if the fertility is desired and they want, normally remember, SUI surgery is not offered to women who are desirous of fertility, who want to have a further child, because that surgery may fail after the next delivery. Okay, so such people, the surgery that is usually done for SUI particularly is the bulking agent can be used. If they are so, if their quality of life is so hampered because of SUI and she's tried all PFMT, everything, she wants a baby in the future and she wants a surgery for the SUI, you may offer her bulking agents because that is a less invasive procedure and that may it could be a temporary procedure, and then later date you can consider her for the major SUI surgeries rather than having her have a child after having done a major surgery. Okay, so there you can consider a bulking agent for her, but you have to refer her to regional MDT. Remember that. Okay. This is also, you could just go through. This is not so important for us to remember from an exam point of view. Now, non-surgical management for urinary incontinence. All urinary incontinence, particularly OAB, caffeine has to be reduced intake. Modify the fluid intake. Ask them to lose weight. Okay. So if you see obese, BMI is mentioned in the exam, look for such options like lose weight. Okay, if she's taking too much of fluid, okay, her output says 3 liters, that means she's possibly taking too much of fluid. Okay, you may need to modify her fluid intake. If she's having too much coffee, you need to tell her to cut down on coffee. Okay, now this is very important from exam point of view. What is it? It is pelvic floor muscle training. When do you offer? It is basically offered for SUI. Okay. Now, patient 60-year-old comes to you with complaints of leaking with coughing, and she wants to know. You've done her urine test, dipstick is negative, and now she wants to know what is the management. What would you tell her? The first step, first management option. What would you tell her? Come on, come on, come on. What would you tell her? This is SUI, right? She comes with leakage with coughing. And remember, when it is SUI, the problem is at the pelvic floor because it's either the hypermobility of the bladder neck, but more recent concept is the mid-urethral support. So you want to strengthen the mid-urethral support. It's simple. So how do you strengthen the mid-urethral support? How do you do? By offering PFMT. So that's the surgery done for SUI. Yes, the exercises. Good, Dr. Anna. Okay, so you will offer her a PFMT. And how long do you offer PFMT? You offer PFMT for 3 months. Okay, supervised. The word is supervised. That means you would have someone show her how to do PFMT and see and monitor that she's doing it right. Okay, so you will offer for SUI, you would offer PFMT for 3 months. Now there is another question that is typically asked here. For SUI, first line management is PFMT. It is offered for 3 months. Which is the other place where you offer PFMT? Can anyone tell me quickly? What are the problem? Now remember, pelvic floor problem you're dealing with, no? So which other problem? Yes, excellent. Very good. So if there is pelvic organ prolapse, you would tell her to do PFMT. How long? How long would it be? Excellent. 4 months, 16 weeks. Okay, so this is you may have option A, option B, and the patient is say SUI or POP. You don't, I mean, that would be mentioned in the question. So you would, if it is POP that is mentioned in the question, you would choose this. If it is SUI mentioned in the question, you would choose 3 months. Okay, so that is how it is. All right, so let's go to the next. All right, can anyone answer this quickly? Which option? Just tell me the option. A, B, C, or D. Quick, 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 quick. Very good. Very good. Everybody agrees with Dr. Seema. Is that right? Can I say Seema? Yes. So it is option B because see, other if what would be the next step if they had asked, then maybe I would choose bladder diary. Okay, because that is like one of the initial steps. But they have asked what is the first line treatment. So my option would be PFMT. Okay, clear? There. This would be the answer. What would be the answer? Right, we just discussed this, so it is going to be A. Okay, if it is the next step that is asked. Okay, so PFMT for your treatment, and one of the initial, if there was urine, I would have chosen urine. Okay, but there is no urine as an option, urine dipstick, I mean, but that's not an option, so I would choose bladder diary if the next step is asked. Then, yeah. Okay, so what does the guideline say about electrical stimulation for management of urinary incontinence? No, it is not usually offered, but it may be offered for women who cannot actively contract pelvic floor muscles to aid motivation and adherence to treatment. So as an initial treatment, who cannot actively contract, like initial cases that I mentioned to you, you can, like when there is a very weak pelvic floor, you can consider electrical stimulation to aid the motivation. Yeah, so that would be it. As far as behavioral therapies for OAB is concerned, what would you do? So first line treatment for OAB. First line treatment for SUI we saw is PFMT. What is the first line treatment for OAB? It would be bladder training. Of course, your conservative measures and lifestyle modification, other conservative measures like lifestyle modification, most importantly, like your smoking and your caffeine and all those things that need to be cut down, you would consider hand in hand with bladder training. And you, when you see such a question, like a patient comes to you with she's a smoker, she's obese, she's a caffeine addict, and she is having symptoms suggestive of overactive bladder. What would you do? You may see bladder training in the options, and you would be tempted to choose bladder training because you know that the first line option of OAB is bladder training. Yeah, but look at the other options. If there is bladder training plus lifestyle, what would you choose? You would choose bladder training plus lifestyle. Okay, is that clear? All right, fine. Then going to the next one. Now, absorbent containment products like urinals and toilet aids uh, are not used routinely, but just as a coping strategy. And when you are contemplating surgery and you're waiting for surgery, your time has not come for surgery. When you're waiting for surgery, then you may consider these. And you may consider these for those where every other option has been explored. She's been offered surgery, maybe multiple times, and now nothing works. And long-term management you need to do, and you need to review these women once a year. This is not very important from the exam point of view. Okay, so again, this is not so important. Catheterization. Catheterization, again, if she has persistent urinary retention, you need to catheterize. Any urinary retention, if you find that there is increase in urinary residual volume, that means there is retention, you need to catheterize her. Okay, and you can offer intermittent urethral catheterization in cases who can be taught self-catheterization. Okay, or they have a career and who can perform the technique well. Okay, so for those, again, this is not commonly asked. Okay, indications for long-term catheterization is just, you can just glance through. It's very pretty simple to understand, not commonly asked. Yeah, so even this is not so important. Just rush through this. Now this is important. This is very important. Medical management. Okay, medical management for OAB. Remember, there is hardly any medical management for SUI. There is one drug which is duloxetine, which is considered as third line. For SUI, it is first PFMT, then surgery, and then duloxetine. Or if she doesn't want surgery, then duloxetine. Okay. But for OAB, medical management is considered as one of the first treatment options if your bladder training does not work. So you have done bladder training, but it has not worked, then you will consider your what is that? The medical management. Okay. Now, important about medical management that you need to know is that the effect is not immediate. You have to wait for the effect to come. So you have to wait for 4 weeks. This 4 weeks again is important. Okay, 4 weeks. You have to wait for 4 weeks for the effect to come. Okay. She may also have side effects when the effect of OAB happens. She may also have side effects like your dry mouth and constipation. Yeah, anti-muscarinic drugs, anticholinergic drugs. Muscarinic receptors are present in the mouth, in the gut, and they secrete in the gut. They increase mobility. So what you can have is dry mouth and constipation. These are the problematic symptoms for your OAB. Okay. So the first line treatment that we consider, the three first line medications, derifenacin, oxybutynin, tolterodine, which is mentioned in the guideline. Okay, of course, there are other drugs as well, which are mentioned in the guideline in the end. But the important ones that are mentioned in the guideline as such is derifenacin, oxybutynin, and tolterodine. What you need to remember about your these medications? Okay, so you need to remember that your oxybutynin is not recommended in elderly. Okay, and why is that? Anybody knows why that is? Your oxybutynin is not recommended in old, frail people. Okay, old, frail, it is not recommended. Why? Yes, that's right. Because oxybutynin is a drug that penetrates blood-brain barrier to a greater extent. Okay, and it affects the cognitive function. Okay, so if there is any neurological problem, the drug that usually does not penetrate the blood-brain barrier is, can anybody tell me? It's not mentioned in the list. Come on. It is trospium. Okay, so it does not cross blood-brain barrier to that great an extent. Okay, so that is what you can use for OAB treatment. Now, offering anticholinergic medicines to treat OAB, consider the coexisting conditions like dementia. You will consider, as I mentioned to you, you will consider trospium in such patients. All right. And any other anticholinergic medications that she is already on. Remember, the side effects are quite severe. Okay. So if there is an option wherein you have to choose between anticholinergic medicines and the next step is say botulinum, you may need to choose botulinum if she is already on some anticholinergic medication. Okay, so that is why it is mentioned in the NICE guidelines as such. Now, next is right. So the NICE guideline specifically mentions oxybutynin immediate release is not to be used in the elderly. Elderly is taken as more than 65, and again, if there is a risk of deterioration of the mental health, you will not prefer oxybutynin immediate release. Immediate release because that has more symptoms. It is immediately released into the system, so it has more side effects. Sustained release or extended release can be considered, but immediate release specifically is mentioned in the NICE guideline. Okay, so you need to offer anticholinergic with the lowest cost to treat OAB. Okay, if the first medicine, this is important, the last 2 points are important here. If the first medicine for OAB is not effective or it is not well tolerated, you would offer another medicine. Okay, like if you give oral tolterodine, it is not tolerated, you will maybe give oxybutynin. Okay, oral. You try and see. Okay, that is how you do. And if they are not tolerating any oral medicines, you can consider transdermal. So it is mentioned in the question that she is not tolerating oral medicines. Do not jump to botulinum. You check if there is transdermal as an option. Is that clear? Okay. So let's go to the. This is about trospium. I was telling you is least likely to impair the CNS function based on neuropsychological and coordination tests. So whenever there is a neurological problem like dementia, you can consider trospium. Then desmopressin can be considered to reduce nocturia, particularly if the patient is having only nocturia, because it will prevent the your vasopressin. It is the antidiuretic hormone, so it will prevent urination. Okay, so that is how it will help in the nocturia symptoms. But it has to be used in caution with cystic fibrosis, and it has to be avoided in those who are more than 65 and having cardiovascular disease and hypertension, because it retains water. It retains water in the vascular system. Okay, so that is why in cystic fibrosis, what happens is cystic fibrosis is anyway a condition where the secretions do not occur, and if you retain water in the vascular system, that is going to worsen the condition. So your lung infections, etc., may increase. Okay, so basically, it acts like a water retainer in the system, so it will not allow nocturia, diuresis. Okay, then. You do not offer hormone replacement therapy in urinary incontinence, but you offer intravaginal estrogen therapy to treat symptoms of OAB. So if she's postmenopausal, she comes to you with symptoms suggestive of urgency, and she has to rush to the loo. She has frequency, she has nocturia, and she has urgency. She comes to you in the postmenopausal period. You have ruled out urinary tract infection. You can consider vaginal estrogen for her, because if there is atrophy. Okay. this is again important. This follow-up questions come in the exam. This comes as an SBA. Okay. Follow-up for anticholinergic medicines after 4 weeks. It can be it's not just a follow-up as such. You can have a follow-up or a telephone review, 4 weeks. Okay. So you can have a face-to-face review or a telephone review for these women. Okay. So that is important for you to remember, right? Then, oh, okay. So, if a woman is satisfied that with the treatment, and if improvement is optimal, you continue the treatment. If the treatment is suboptimal with drugs, I'm talking about now, or there are intolerable adverse effects, you change the dose, try alternative OAB medicine, and review again after 4 weeks. Okay, so this is important for us. So I've made a chart about this. I'll show you the chart. Offer a review before 4 weeks. Okay, so all women have to have a review at 4 weeks, but you may need to see them before 4 weeks because they may have adverse events for a medicine which is intolerable. Okay, and if in these cases you can refer them to secondary care and for further treatment. Okay, and you offer a further face-to-face or telephone review if medicine of for OAB or urgent causes stops working after initial successful 4 weeks review. Okay, so if she stops working, I mean, if you have started, it is working initially and it does not work, then you offer another face-to-face review if it is stopped working. Okay, and for those women who are satisfied with their treatment, you can offer follow-up every 12 months or 6 months if they are more than 75. So those who are on long-term medicine. I've made a chart on this. I'll just show you in a bit. What you need to understand is mirabegron is used if these initial drugs are contraindicated. Okay. So I'll just show you that chart in a bit. This is maybe a bit difficult to understand. Contraindications are mentioned in one old dog article. It is anticholinergic contraindication is where myasthenia gravis exists. So here there is the neuromuscular junction problem in myasthenia gravis. So that will be worsened with anticholinergic. So you don't want that to happen. So if there is significant bladder outlet obstruction. So if you give anticholinergics, the bladder is going to further relax against an obstructed outlet. Not good. Severe toxic megacolon. That means your colon is relaxing. Basically, cholinergics will help the colon to contract. Anticholinergics will cause constipation, as we have seen earlier, because they make the colon further relax. So if it is anyway dilated, it will further have problems. Similarly, ulcerative colitis or gastrointestinal obstruction or atony. And mirabegron is contraindicated in severe hypertension. So just look for these things in your questions if there are any contraindications to anticholinergics. Like if they mention that the patient with myasthenia gravis has come to you with OAB symptoms and she has now not responded to bladder training, please remember that you cannot give her anticholinergics. All right. Now, so the chart that I was talking about is here. Drugs for OAB would be tolterodin, oxybutynin, derifenacin, trospium. What do you do if you have started? When do you see this patient? When do you see? When do you see? How do you follow up? Basically, this chart is about follow up. When do you see the patient? After 4 weeks. Good. Telephonic or face-to-face review. At 4 weeks, you have to see improved. You continue. You continue. And if she is more than 75 or elderly, so you may have to review her more often. So every 6 months. If she's less than 75, you review her every year. Simple. If there is no improvement or it is not tolerated, what do? You give an alternate medicine and review after another 4 weeks. Okay. If there are side effects with oral, any oral that you have tried. You have tried after 4 weeks, another oral maybe. That also has side effects. Remember, if there are significant side effects, you will not wait for 4 weeks. You will review her early and change the drug or change the dose, etc. Okay, that is that we have seen. If she has significant side effects, you review earlier. So if there are significant side effects with oral, you change even before 4 weeks. You change to transdermal. Okay. Second line is mirabegron. Clear? Right. Now, invasive procedures. As we have seen before, treatment of diffuser overactivity, you will do treatment as in before the invasive procedure for diffuser overactivity. Which is the invasive procedure for diffuser overactivity? Here it is. Botulinum. Because botulinum is a muscle relaxant, right? So remember people using botulinum on face so that they don't get wrinkles, so the muscles don't contract and the wrinkles don't form. So you use botulinum for muscle, relaxing the muscle. That's a toxin that is used for relaxing the muscle. So when you use botulinum, you have to be very sure it is indeed diffuser overactivity, because you're otherwise unnecessarily going to relax that bladder and cause retention. So you need to do urodynamics. Okay. You send, if it is pure OAB, you will send to local MDT, then urodynamics, then botulinum toxin. Okay. Now, if OAB symptoms caused by diffuser overactivity, not responding to non-surgical measures, you will offer bladder wall injection of botulinum toxin. Okay. OAB symptoms, but if you do urodynamics and you still see that there is no diffuser overactivity, okay, but she has symptoms of overactive bladder, you have treated for UTI. But the very fact that you have done a urodynamics, that means there is no UTI. Okay, there is no diffuser overactivity, but she has symptoms. Now what do? Do you still treat or do you not treat? She's not responding to any of the non-surgical management, and she does not wish for any other invasive treatment. You can consider bladder wall injection of botulinum. Consider. Word is consider, because it is not actually proven diffuser overactivity. Okay. OAB symptoms, no diffuser overactivity on urodynamics, not responding to non-surgical management, and do not wish for any other form of treatment, you can consider botulinum. While if you have proven that it is diffuser overactivity and she has not responded to anticholinergics, there you can offer botulinum toxin injections into the bladder. Got it? All right. Now, next. What is the prerequisite for botulinum toxin? That you need to teach them how to catheterize, because when you relax the bladder, it may go into a retention. Then what will you do? Then you need to catheterize the bladder, empty the bladder. So you need to perform clean intermittent catheterization, or sometimes they may need a temporary indwelling catheter. Okay, so look for these things as well in the exam questions. If they say that the patient is not willing for intermittent catheterization, you will not treat her with botulinum toxin, or intermittent catheterization or permanent catheter, indwelling catheter. You may not treat her for with. So this is a prerequisite for botulinum, because botulinum relaxes the bladder and it can cause retention. Okay. Use 100 units of as an initial dose. Now the talk on refractory OAB management mentions about 100, 200, and how there is a kind of a debate whether you use 100 or 200. But nice guidelines, it says 100, so stick to 100. First is 100. If that doesn't work, then you can increase. Review for after invasive procedure, that is botulinum toxic, after 12 weeks. So what we have seen so far for anticholinergics, you review in 4 weeks. For botulinum toxin, Botox, in the bladder. You review in 12 weeks. These are important questions. Okay. So if there is good symptom relief, you can tell her to go back and come whenever necessary. If she gets symptoms again, you can treat. However, if there is inadequate symptom relief, you can consider another dose of botulinum and increase the dose now to 200 and review again in 12 weeks. Okay, is that clear? Inadequate, you can review. Inadequate, you can increase the dose. Okay, and review within 12 weeks. If it is adequate, you tell her that she can come back if there are symptoms that occur, and then you can consider treatment with the same dose. Okay, that is what it is. Now, okay, so this is another thing which may be asked. Percutaneous sacral nerve stimulation. What happens here? Sacral nerve is the nerve that supplies the bladder. Okay, so if it is supplying to the bladder, you can manipulate the nerve to contract or relax the bladder. Okay, so basically you are kind of stimulating the nerve into such an extent that it becomes like kind of paralyzed. So what you're doing is you are preventing the bladder contractions from occurring. So for this, you after a local or a regional MDT OAB review, you can consider percutaneous sacral nerve stimulation if the symptoms are not responded to botulinum toxin or not prepared to accept the risk for catheterization. So if there is a question to you in the exam where she has not responded to medicines, okay, she has not responded to medicines, she has OAB symptoms, detrusor overactivity is proven, what is the next step? Okay, the next step would be botulinum, provided she is agreeing to do self-catheterization. If she's not prepared to accept the risk of needing catheterization, then you can do percutaneous sacral nerve stimulation. Okay, right? If they have not mentioned anything about catheterization, you can choose Botox. But if they've specifically mentioned that she does not want to have catheterization, then percutaneous nerve, right? Clear? Okay. Transcutaneous stents is never offered. Do not offer transcutaneous posterior tibial nerve stimulation either. Offer percutaneous posterior tibial nerve stimulation. So only percutaneous is offered. Percutaneous. Trans is where you stimulate by putting the probe on the skin, just touching it on the skin. Percutaneous is you have to insert those devices inside the nerve, on the area of the nerve. Okay, so this is percutaneous is always offered whenever it is to be offered. Transcutaneous is never offered. Okay, now percutaneous sacral nerve will be offered if botulinum is not working or if she's not willing for your catheterization. Posterior is offered if there has been an MDT review and the woman does not want botulinum or percutaneous sacral nerve stimulation. This is because to put that probe or to put that transducer, sorry, not the thing, the transducer into the sacral area, you need to give a skin incision. Okay, and you need to put it in the sacral area. So if she's not willing for that, tibial insertion is much easier. It's on the leg. Okay, so you can consider tibial if she's not willing for percutaneous and she's not wanting botulinum toxin and non-surgical management has not worked. Okay, so all of these have to be fulfilled for you to offer posterior tibial. Now, of course, there is a chart on this as well, which I'll show you. So you can have the clear idea. Augmentation cystoplasty is the next step if none of those things have worked. Remember, one of the questions here is Metabolic acidosis is a side effect. Okay. Then urinary diversion is the next method, which is again not frequently asked. Let us see the chart. Let me know if you are tired. If you are tired, then we could stop. Okay, otherwise I could go on and on. First is, let's see about OAB. Okay, what would you do if there is OAB? Next step, quickly. I want all of you all to contribute. What is the next step? Symptoms suggestive of OAB, I mean. Quickly. Symptoms suggestive of OAB. What would you do? What would you do? Initial step. Remember the first slide. What is the initial step? Yes? No one? Dr. Anam? She's not there? Okay. I got a private message. Yes. So the first step would be to do a dipstick. Okay. That's in the clinic that she's come. You can straight away do a dipstick. Then you tell her to go home and come back with a, what would you ask her to do next? What would you ask her to do? Bladder diary. Yes, excellent. Next, remove any factors that may precipitate the problem. Okay, the lifestyle modification. Lifestyle modification would be your weight loss and all those things. Bladder training. Okay, so bladder training is given for 6 weeks. That doesn't work. Next is medicines. Medicines, I've showed you another chart what is to be done. You start one, review in 4 weeks. If it's fine, you continue. You review in 6 months or 12 months, depending on the age and other factors. And if it is not working, then you can switch to another oral. Again, review in 4 months. If there are significant side effects with oral, transdermal. And if all those medicines are not there, then the second line not working, then second line is mirabegron. Okay. Then, if that doesn't work, next step is not directly BOT. You have to give referral to a local MDT. If there are complex pelvic floor problems, then regional, but otherwise local MDT. Urodynamics has to be done, as I told you, before any invasive procedure for reduced overactivity. Next step is sacral nerve stimulation. Okay. And augmentation cystoplasty and your urinary diversion. Okay. This is the flowchart. This is all that you need to remember for the exam. Is that very clear? Clear? Clear so far? Hello? Yes. Okay. Pi is yes. I keep forgetting. Okay. So you are clear. Now, next. Okay. I hope we can continue. Are you tired? Is anyone tired? If you are tired, let me know. Okay. We can wind up. Okay. So if there is stress urinary incontinence and your PFMT has not worked, then the next step is in stress urinary incontinence is straight away surgery. So what is preferred in stress urinary incontinence is your autologous, your Colpo suspension. Okay. Now, retropubic mesh repair can be considered, but remember mesh has problems. So that is why the NICE guidelines has put autologous rectus facial sling here first before a retropubic mid-urethral mesh sling, which they have mentioned is an option. But what they have mentioned is first is Colpo suspension, then your autologous rectus facial sling. Now, how to choose between these two? Because there is no definite option that is always preferred. Now, if you have pure SUI, then you can do a laparoscopic colposuspension because it is it is associated with a quicker recovery if it is done laparoscopically and colposuspension. But if the patient is having some vaginal issue, or say there is some anterior repair that you need to do because of a cystocele, and you are considering doing a surgery for SUI as well. Now, whether you always do a surgery for SUI along with anterior repair is a debatable issue. But if the MDT has decided that the continence surgery for SUI along with vaginal repair of the cystocele would be done simultaneously, then rather than going abdominally and doing a colposuspension, you could just do both the procedures vaginally. Okay, so it is less extensive for the patient and it is easier to perform because it is both the procedures can be done vaginally. Then you can consider this. Okay, so otherwise, in if it's there's one option that you have to choose for pure SUI, you would choose laparoscopic colposuspension. Okay, but if she has to say undergo this procedure for any other vaginal procedure that she has to undergo, and you want to consider together with that sling surgery, I mean SUI surgery, then you can choose this. But if alone SUI, you will choose laparoscopic colposuspension. Okay, is that clear? So the surgeries that are recommended are those two, autologous and colposuspension. Autologous rectus facial sling. So you take a facial sling from the rectus sheath and you do a colposuspension. I mean, or you do a colposuspension. Retropubic mesh can be considered as an option. Now, bulking agents. Remember, they are permanent injectable materials that are inserted into the around the urethra so that the continence is maintained. Repeat injections may be needed. Uh, it is less effective than surgical procedures and effect wears off over time. And it has limited evidence. What is mentioned in the TOG article is that they can be considered if the woman is desirous of fertility. Okay. So you don't want to do a incontinence surgery as such because she would have another pregnancy which will worsen the or result in failure of the surgery. So in those cases, you can consider this particular option. Okay. So um, mid-urethral mesh sling surgery can be considered. It has to be a colored it has to be a colored mesh sling surgery. Okay, so this one. You should not use transobturator. Top down, no. It is just a retropubic small mesh that can be put and it has to be colored. Remember that. Okay. Then next is artificial is not usually asked and it's not that important. You just need to just glance through. SUI procedure that should not be offered for SUI is anterior colporrhaphy. Like if you see that there is a prolapse, anterior prolapse, that is a cystocele is there, and she has SUI, don't think that you will offer her colporrhaphy and she'll get better. She may, but may not always be. So it should not be offered with the intent to cure the SUI. It should be offered for the cystocele. Need not be offered for the intent to cure the SUI. So also these needle suspensions, paravaginal defect repair, porcine dermis sling, Marshall-T Kranz procedure should not be offered. Another follow-up question. Now earlier we said OAB drugs, revising, okay? Drugs is 4 weeks. Botulinum, 12 weeks. SUI surgery, 6 months. Similarly, POP surgery, 6 months. Okay. So a follow-up appointment within 6 months should be offered for all those who have surgery for SUI. Okay, as simple as that. Just that you need to know from here. Then, okay, so if there is a relapse, remember we have already seen this, regional MDT would come in play. Duloxetine, not first line, not second line, it is used as a third line. Or if the patient is not wanting to have a surgery, then you can use duloxetine. It is a, what drug is it? Anybody knows? What drug? Come on, what drug is it? Anyone? It is a SNRI. Okay, selective serotonin noradrenaline reuptake inhibitor. Okay, so important side effect, major side effect is nausea. Okay, so that is what you need to know about duloxetine for the exam. Then yes, Dr. Anam knows all the concepts, isn't it? So SNRI, yes, that's right. So SUI, let's go with SUI. So SUI, if there is a problem of SUI, what would you do first? You would do a urine dipstick, correct? Right? All incontinence, you do a urine dipstick. If after that, you would do PFMT for 8 contractions 3 times a day for 3 months. Okay? Weight loss. If that fails, MDT. If that fails, surgery, colposuspension, sling, bulking agents. And if that fails or she's unfit, duloxetine. This is the flow for SUI. Is this very clear? Any questions? Right? Okay. What we have seen earlier is that you do not do urodynamics as the first line investigation for pure SUI. Okay? You do urodynamics for OAB before surgery. You do not do urodynamics for SUI before surgery if it is only SUI. You do urodynamics for SUI surgery before SUI surgery if there are those 4 indications we have seen earlier. Okay, so that is it. And this is something that you may be asked in the exam. What you need to know is duloxetine is an SNRI and oxybutynin is non-selective, which is why it is not a very good drug as far as side effects is concerned, but it is very effective. And derifenacin and solifenacin are uroselective, although they have other side effects, but they are more uroselective. Okay, and this drug propivarin is used in Japan, and it is anticholinergic and a calcium channel blocker. This is mentioned in a TOG article, which is quite old. Okay. Do you want to proceed or do you want to stop here? Please tell me. Depending on that, we can proceed. We can decide. Yes, Dr. Anam. Dr. Manikam. Who's go-to? May I know who this person who's joined as go-to? Can you please message me your name, please? Hello. Hello. Okay, yes, Dr. Anam, what do you want to do? Do you want to continue to pelvic organ prolapse? Oh, that's nice. So we'll continue. Okay. So since you are the only one who is responding here, so okay, fine. So pelvic organ prolapse, let's check the flow. So basically, as we have seen for urinary incontinence, here you do history taking, and then you check whether it is there are urinary symptoms, bowel symptoms, sexual symptoms. I mean, sexual function is affected or not is important, and do an examination about the pelvic mass. And when you're managing the patient, you have to take her preferences into account, see where the prolapse is, lifestyle factors. This is more important for part 3. You will not be asked a question on this, but this is important for history taking in part 3 examination. Now, this is very important for us. So, what is this? This is POPQ. Now, remember, POPQ is a method that is used for staging the prolapse. Okay. There are points on the anterior abdominal wall, and depending on where the anterior abdominal wall goes, you will have your measurements of these points. Similarly, there are points on the posterior vaginal wall. Okay. Now, on the anterior vaginal wall, there is this point which is called AA. What is it? It is a fixed point. Okay. It is a fixed point. Why fixed? Because it is always measured. It is not always there, but it is measured along the length of the anterior wall, 3 centimeter proximal to the hymen. Similarly, AP is a fixed point here, 3 centimeter proximal to the hymen on the posterior wall. BA and BP is any point here which is dipping down. I mean, which is the when there is a prolapse in the anterior wall, when there is an anterior wall prolapse. For example, let me draw it for you. So if there is this is a normal position of the vagina and the uterus. Now, if there is a anterior wall prolapse, this is the uterus. The posterior wall is fine, but there is an anterior wall prolapse. Point AA is a fixed point here. AA is a fixed point. You will only see where that point A goes to when you are marking point A. BA, on the other hand, is anywhere here, which is the most distal point here. The most distal point when there is a prolapse. When there is no prolapse, the point which is most distal on this area is same as A, because this is the most distal point. Distal is the lowermost point. Okay, here. So A corresponds to BA when there is no prolapse. But when there is prolapse, you will always mark this AA as 3 centimeter along the wall and see where the AA has gone to, and you will check where that BA point is. Okay, that is the most distal point on the anterior vaginal wall. Is that clear? Or do you want me to repeat that? Is that clear? Hello? Did I see a yes? Is that clear? Yes. Okay. Similarly, if you have let me show you the posterior wall. Okay, on this posterior wall, AP is a fixed point, which is always taken 3 centimeter proximal to the hymen. And what you see when there is posterior prolapse is whether that AP point, okay, whether that AP point is going down. So if there is a bulge here, posterior, okay, this is the hymen. So this is a point 3 centimeter proximal, which is AP. It has come at the level of the hymen, it becomes 0, okay, over here. And BP is the point on this area, the most distal point. So here. So this is how you quantify pelvic organ prolapse. Okay, for anterior and posterior vaginal wall, that is. Now for the top, that is the cervix and the posterior fornix. Posterior fornix and the cervix. Cervix is 2 centimeter lower than the posterior fornix. So posterior fornix is marked as point D, while your cervix tip is marked as point C. Okay, and when there is hysterectomy done, there is no D and C, so it is only C. Okay, clear? And you have your perineal body and you have your genital hiatus. Perineal body is from here to the midpoint of the anus, from the posterior fossa, and genital hiatus is from the front, that is your the clitoris, to the posterior edge of the hymen or the posterior fossa. So these are the markings that are mentioned in the POCU grid, and you have the total vaginal length, which is the length here, this length. Okay, as you can see here, this length. So it is measured. Even if there is a prolapse, you put it back and you measure the posterior vaginal, the TVL, by putting the prolapse back. Okay, is that clear? Any questions? Yes, thank you. So how do you quantify prolapse? So basically the significance of this is that if it is anterior wall, it is in the lower part, it is usually a urethrocoele. If it is an upper part, it is a cystocele. Similarly, posterior wall, lower 2/3 is rectocele, upper 1/3 is enterocele. Okay, it is just the opposite on the anterior and the posterior wall. But that's what is important here is that you need to know the staging, because they may ask you the staging. They may give you the value of AA, AP, and so on and so forth, and they may ask you staging. So if it is stage 0, means there is no prolapse at all. Every point is in the normal phase, a normal state. So AA, AP, BA, BP all are at -3. C and D is up, higher up. If stage 1 means it comes down, but the lowermost limit of the prolapse. So if it is, this is stage 0, say, okay, this is the hymen. Now what is stage 1? This is the hymen. This is when it comes anywhere between, say it comes down here or it comes here, but it is still 1 centimeter above the hymen. The lowermost limit is 1 centimeter above the hymen. Okay, so it is anywhere between 0 and -1. What is stage 2? Is anywhere between -1 here across the hymen to +1. That is stage 2. Stage 3 is anywhere beyond +1 till TVL -2. And what is TVL -2? When the entire prolapse, let me draw again. When the entire uterus comes out, the uterus is normally like this, no? When the entire uterus comes out, okay, it's coming out, it comes with the cervix here. This posterior part gets obliterated. So TVL will, the entire TVL which is there, which this upper 2 centimeters is not really present in the vaginal length that comes out. So it is TVL, the maximum that can come out is TVL -2. Okay, because that posterior fornix, which gives it an additional depth, is gone because the entire cervix comes out over here. Okay, so that depth is only inside when the uterus is in the abdomen. When it comes out, the depth gets obliterated. So the maximum depth is TVL -2. Okay, so that is called as precedentia or stage 4 prolapse. All right, clear? Clear? Yes? Okay. What is this answer? What is this answer? I've still not got a response. Who is go to in the meeting? Never mind. Okay, can you tell me what the answer is, please, Dr. Anna? Yes? What's the answer? All right, so what is that option? B, right? So the option here would be B. Okay, so because you can see that your BA has come out. So the anterior A has come down means BA or AA is anterior wall has come down. AP and BP are at -2. So it's not significant, but BA has come down quite significantly. So it is stage 2 and it is +1. So it is beyond, it is between -1 to +1. So it is beyond the hymen 1 centimeter. So it is stage 2 and it would require an anterior repair. What is this?
Stage 2 rectocele with posterior repair.
Yes. Answer is C. Because it is again AP and BP have come down. Okay. TBL is 9 and D is -7. So ideally D should have been -9. There is some degree of vault descent as well. But major problem here is the posterior one because it has significantly come down. AP has come to 0. That means at the hymen. Okay. So management would be lifestyle modification, topical estrogen, and estrogen ring can be given. Okay. And PFMT, as we have seen earlier, PFMT for, just to revise, for SUI is 12 weeks, that is 3 months. For POP, it is 16 weeks. Okay, and it is usually done for stage 1 and stage 2 prolapse. Okay, pessaries also have to be changed at least every 6 months. If they can change earlier at home, that's fine, but otherwise, at least every 6 months they have to change. Okay, well, this is not so important. And surgery for pelvic organ prolapse. So if the symptoms of pelvic organ prolapse have not improved with conservative measures, and if she has declined any conservative measures, you can do a surgery. Okay. And do not offer a surgery to prevent incontinence in women having surgery for prolapse who do not have incontinence. What does this mean? If there is anterior cystocele, do not do a cystocele repair, and at the same time do not do a surgery for SUI if there is no previous SUI in her. Okay, so yeah, so but you need to tell them that post-operative urinary incontinence may happen. Okay, so that is what is mentioned here. Then, what are the surgeries that you do for prolapse? Most common one that is done is vaginal hysterectomy with or without vaginal sacrospinous fixation with sutures. Remember, when you choose the surgery, again, like in SUI, I told you, if you're doing a vaginal route, if you've chosen a vaginal route, it makes sense to choose sacrospinous fixation. Okay, because you're going vaginally, and sacrospinous fixation is done vaginally. Rather than going abdominally and doing a sacrocolpopexy or other procedures, you can do it vaginally. Okay, you fix the vault vaginally. You can do vaginal sacrospinous hysteropexy with sutures if the patient wants to retain the uterus. So you go posteriorly. It's like it's the pelvis. Okay, the pelvis. This is the symphysis. This is the sacrum, and there is the uterus which is falling down, and the pelvis has the sciatic notch, sacral spines. I mean, sorry, the ischial spines, which has the sacrospinous ligament here. The ligament is here on the ischial spine. What you do is you go vaginally from here. You lift up the vault and you put sutures here so that it remains at this level. Okay. If you want to preserve the uterus, you take the full uterus up and suture here. So that is vaginal sacrospinous hysteropexy with sutures. Manchester repair is where there is cervical elongation typically and it comes down. You cut the cervix and you put the McIntyre's ligaments which are at the side and the uterosacral ligament which are behind. You cut them and you put them in front so that they will pull the uterus behind. That is Manchester repair. Okay. Just for an idea, nobody is going to ask you what surgery, just a rough idea. Sacrohysteropexy with mesh is done abdominal or laparoscopic. This is like sacrocolpopexy for vault. So again, you have the pelvis, you have the sacrum, you have the pelvis. What is done in sacrohysteropexy? You have the uterus. Okay, it's falling out. So you put a mesh here this way, and you put it up on the sacrum. Attach it to the anterior longitudinal ligament of the spine of the sacrum. That is sacrohysteropexy with mesh. Okay. So vaginal hysterectomy with or without vaginal sacrospinous fixation. You can do or you can just leave it there. Okay. Vaginal sacrospinous hysteropexy. Okay. Wherein this is if she wants to preserve the uterus. Manchester repair is also preserving uterus. Sacrohysteropexy is also preserving uterus. Only vaginal hysterectomy is removing the uterus. Okay, so that is if she wants to preserve the uterus for whatever reason. Okay, so these are the operations that are offered for pelvic organ prolapse. Are they clear? Clear? Clear or not clear? Very good. And also remember, the surgery is directed to the prominent prolapse. That is the importance of POPQ. That means if there is an anterior prolapse, there is a apical prolapse, and there is posterior prolapse. Sorry, this is the uterus, and there is a posterior prolapse. This is anterior. This is posterior, anterior, posterior, anterior, posterior. So this is the rectum. Here is the bladder. When this is the case, you will do anterior repair, anterior colporrhaphy. You don't have to touch this area if this is not descending. If this is the case, you do posterior repair. If this is descending, anterior, I mean the apical prolapse, this is the apical. Then the surgeries that we mentioned earlier, hysteropexy and vaginal hysterectomy with sacrospinous fixation, Manchester repair, and your sacrohysteropexy. Okay, all those things are done if you want to preserve the uterus, sacrohysteropexy. Okay, so those surgeries. And if there is vault, if there is no vault, I mean, if there is no uterus and the vault is normally like this, but if the vault has descended down, then you will do these two surgeries: abdominal sacrocolpopexy or sacrospinous fixation. Clear? Clear? Very good. Okay. So remember, if there is a mesh related problem, this is a mistake, spelling mistake, reported to MHRA. Okay, that can come as a question. What happens? What do you do when there is a mesh related problem? First of all, you follow up after 3 months. Now remember, SQI surgery, pelvic organ prolapse surgery, is followed up after 6 months. But mesh is a problematic thing, so you offer follow up earlier. So if there is a vaginal mesh exposure, you can give estrogen cream if the area of exposure is less than 1 centimeter square. Okay. And if you may need to offer imaging to see where the mesh has gone and further treatment if there are signs of infection and vaginal mesh exposure or extrusion. Okay, so this again can be asked. Then, yeah, this is something important. This is something that I want you to know about surgery for both. If there is, say, if there is anterior cystocele and there is SUI symptoms both, both are treated surgically. Of course, they are treated with PFMT initially, but if that doesn't work, both are treated surgically. Now, whether the surgeries for both are different. Anterior cystocele will be treated with anterior colporrhaphy, and SUI would be treated with either a Birch colpus suspension or your retropubic sling. So whether to offer both the surgeries together or not is the question. Okay, so NICE guidelines would mention that you need to consider concurrent surgery for SUI and pelvic organ prolapse in women with anterior apical prolapse and SUI. Of course, anterior apical prolapse and SUI before surgery, what do you need to do? What do you need to do quickly?
Urodynamic. Urodynamic.
Very good. Very good. Okay. When considering concurrent surgery for SUI and pelvic organ prolapse, discuss the options of treatment and explain to the woman that there is uncertainty about whether the combined procedure is effective for treating SUI beyond 1 year. Okay. And the risk of complications because you're offering two surgeries at the same time. So there is what NICE mentions is that there is uncertainty about offering both the surgeries together. That is what is mentioned still in NICE guidelines. I'll tell you what is mentioned in the COG article on continence. Okay. These are important points which I had discussed even the other day in the group. The important time period for follow-up. Pessary change 6 months, sling surgery 6 months for SUI. SUI surgery and pelvic organ prolapse surgery is for 6 months. Okay, so that both are 6 months, and OAB drugs less than 75 is 12 and more than 75 is 6 months. And we also saw mesh is 3 months. Mesh is the earlier one for after surgery. Otherwise, both the sling surgery for SUI and your prolapse surgery is 6 months. Mesh is 3 months. Remember that. Okay. So, yeah. So just again this revision of the basic measures. Okay. First line management SUIs, lifestyle modification, and urge incontinence OIB. First investigation is urine routine. These are the common questions that they may be asked. Okay, and first line drugs are these. Okay, first line surgical management in OAB is botulinum toxin. First line surgical management is SUI is colpo suspension. Okay, but as I mentioned earlier, and it is going to be laparoscopic because that is better for the patient. As I mentioned earlier, if there is vaginal approach needed for other indications, then you can do autologous facial sling, rectus facial sling. All right. So that would end our guideline on NICE guideline on SUI and urinary incontinence and your pelvic organ prolapse. Any questions? Next is I still have post-hysterectomy vaginal wall prolapse to discuss. You let me know if you're tired, then we can stop and maybe do it some other time.
You didn't complete if there is concomitant, urinary stress incontinence and prolapse.
Sorry, I didn't get your question.
If you have both stress incontinence and prolapse, so shall we go for both surgery at the same time?
Yes. Let me show you that. Give me a moment. I have one more slide for that. It's a very, very interesting question. Okay. All right. Yes, I found it. Let me just display it. Okay. Can you see this? Okay. So this is what is mentioned in the TTG for wall prolapse. Okay. They say that wall prolapse is a apical prolapse. It's like almost the same as your anterior wall prolapse, and it behaves the same way for clinically. So if there is wall prolapse, colposuspension, you would need to do, and if there is occult SUI, okay, occult means she doesn't present with SUI, but when you reduce the prolapse and you check her and you ask her to cough, there is leak. Okay, possibly she doesn't present with SUI because the prolapse is kind of causing the kink on the urethra, which is preventing a leak. Okay, so in such cases, colposuspension is performed at the time of sacrocolpopexy is an effective measure to reduce post-operative symptomatic SUI. So if there is occult SUI, that means where SUI is not clinically, significantly present in history, but on examination after reduction, you see SUI. If there is occult SUI, you can consider doing a abdominal sacrocolpopexy for the wall prolapse plus Birch colposuspension. This colposuspension is Birch colposuspension. Because studies have shown that this may help. Okay, that is why for occult it is this which is done. Now, if there is overt SUI and you're doing a surgery for prolapse, okay, you would do a colposuspension at the time of, a colposuspension at the time of abdominal sacrocolpopexy does not appear to be effective treatment for SUI when it is overt. When it is overt, it is better to treat with mid-urethral sling surgery when you are doing a vaginal approach for PHPP. Okay, most of the prolapse that you treat vaginally usually. Okay, unless it is just a walled prolapse, which is treated abdominally by sacrocolpopexy. But if you're treating vaginally the walled prolapse, say you're doing a sacrospinous fixation vaginally, and she has a overt SUI, you can do basically what you can do is vaginal correction of the wall. So you can do an SSF plus retropubic or your sling surgery, basically sling surgery or SUI, because both these are done vaginally. So the evidence suggests that you would do concomitant mid-urethral sling surgery with vaginal surgical approach for PHPP. So just to revise, occult, what helps as per evidence is abdominal sacrocolpopexy. Now this is occult with both with pelvic organ prolapse. Okay, plus occult ASC plus Birch colposuspension is shown to be more effective. If it is overt SUI, okay, what is shown to be more effective is vaginal approach. So vaginal approach is SSF, sacrospinous fixation, plus sling for SUI. Got it? Clear?
Sling, you mean rectus sling?
Yes. So preferred is rectus sling. Retropubic mesh, it's also a sling, kind of. A sling meaning it's a mesh, retropubic mesh. May be considered, but mesh has its problems. So the one you choose first is rectus facial sling surgery. Okay?
Yeah, okay, clear. Thank you.
This is as per the GTG. Now, there's a TOG article on this. Here. What does the TOG article say? there is a debate. It's not clear about offering both the surgeries together, which also NICE guidelines mention that you need to explain to patient, and it is not very clear whether both the surgeries should be offered together. Now, what the TOG article concludes is, despite concomitant continence surgery, SUI can still persist in approximately 1/3. So even if you offer surgery, it can persist in 1/3 of the women. If you offer both surgeries, surgery for pelvic organ prolapse and SUI. So this poses a clinical dilemma whether to offer it at all. The second thing that they say is that if you just offer a prolapse surgery alone, 1/3 women will have improvement of SUI. That means there is a good chance that just with the prolapse surgery, SUI also would get treated. So whether the question is whether to offer both the surgeries together or not, because obviously both surgeries means two different surgeries would mean more complications. So whether to offer or not is still a debatable issue as per the TOG article. So some studies have shown that although SUI may persist or develop after pelvic organ prolapse repair alone, not all women opt for further surgery. Okay, so what they are saying is that if it persists and you have done the surgery and it for both pelvic organ prolapse and SUI, and now the SUI is still persisting, then the further surgery women may not opt for because it is difficult to do a further surgery. So again, whether to offer the SUI surgery earlier or you would offer it later when SUI becomes manifested, that's a question. Okay. So basically, the whole problem here is, as per the TOG article and the NICE guideline, that whether it is to be offered or not, again, has to be an MDT discussion, and whether it's going to help the patient at all is a question. But if they give you specifically, as per the GTG of walled prolapse, if they give you specifically occult SUI, and you have to say if the MDT has chosen surgery, then the option that you choose is ASC plus or abdominal or laparoscopic, whatever that is, purge corpus suspension. Okay. If they say it is overt SUI with pelvic organ prolapse, you will choose, say it's a walled prolapse. The organ prolapse is a walled prolapse. Then you choose sacrospinous fixation, or maybe sacrohysteropexy if there is uterus, sacrohysteropexy plus your facial sling surgery. Okay, this is the only thing that is conclusively mentioned anywhere, but most of the evidence is saying that it is debatable. All right, is that clear? Do you want to proceed, or do you want to? What do you want to do? Yeah, Dr. Annam, what do you want to do?
If you have time, and up to you. If you want to proceed.
Okay. There is the two TTGs we can discuss, the bladder pain syndrome and the pelvic organ prolapse, because there are not many slides on that. It's basically the chart for the bladder pain syndrome, and this that will just revise. Okay, so wait a minute. Okay, let me share. Fine. So the GTG on post-hysterectomy vaginal wall prolapse 2015. What are the points? Important points here. This is important. At the time of vaginal hysterectomy, for prophylaxis purpose, you will do McCall cultoplasty. If it would help if you're doing a vaginal surgery, vaginal hysterectomy, it would help in preventing further prolapse. Okay. For that matter, McCall, if you know what McCall is, I mean, it always helps to understand what the surgeries are. McCall's this is the when you have the vault, after removing, you have just the vault, right? This is the open vault. Okay, you have removed the uterus from there, and the your uterosacral ligaments are here. Okay, and there is from here, this is the hole that goes into the peritoneum. This is the hole that goes into the peritoneum. So here you have the posterior peritoneum overlying the rectum. What you do in MRCOG is you take a suture here, go through the vault, take a suture on the posterior peritoneum, same suture, go through the uterosacral here and the vault out and tie the suture across. So what happens is this uterosacral, the posterior peritoneum and the vault is at the same level. That is MRCOG. Okay. So if you do that, it can suspend the vault at the level of the uterosacral and the posterior peritoneum. But remember what goes close to the uterosacral? What goes close is your ureter. So this can injure the ureter. That's important. Okay. At the same time that you're doing vaginal hysterectomy, other option that you can do is a sacrospinous fixation. And what the GTG says is you consider when the wall descends to the introitus. Okay. Then the other thing that you can do at the time of hysterectomy abdominal that we usually do is suturing the cardinal ligament and the uterosacral ligaments to the vaginal cuff at the time of hysterectomy. Okay. So you can do abdominal during abdominal hysterectomy as well as the vaginal hysterectomy. So these are the preventive measures for you can get which of the following can be used or which of the following is not an option. And then you may have all these in the options and one may not be the option that is given in the guideline. Okay. Then subtotal hysterectomy is not recommended for the prevent. Like you think that if you keep the cervix, subtotal is where you keep the cervix back and that will help in suspension. That is not true. Okay, it is not recommended. Use of permanent sutures, whether you should use permanent sutures so that it stays up. The evidence is conflicting and long term there is no evidence of benefit. So whether you should prefer permanent over delayed absorbable. Again, this is more important for part 3 exam because they may ask in structured discussions. Now, this is another important table about abdominal sacrocolpoplexy and sacrospinous fixation. What we need to understand is it has a lower rate of recurrent wall prolapse. It has a lower rate of dyspareunia, lower rate of post-op SUI, and okay, so this is the last column. Row is not important. While SSF is early, I'll tell you the reason now to remember. Early recovery, it is not appropriate for short vaginal length. It is if there is pre-existing dyspareunia, you have to worry about it. Now, what is this? In abdominal sacrocolpoplexy, remember you are lifting the vault higher up at the level of the sacrum. I mean, not at the level of the sacrum as such. You are lifting it higher up and suspending it on the anterior longe. This is the vault. This is the pubic symphysis. This is the sacrum. Okay, I'm showing you a sagittal plane. This is the vault. What you're doing in abdominal sacrocolpoplexy, you're putting a Y mesh like this over this, and you're suspending it here. What happens in a sacrospinous fixation is this is the sacrum, pubic symphysis. You are taking the vault and putting it behind like this. This is proper. This is a little more horizontal than usual. So what is happening here is here you are putting it. No, there is a spine. What happens here is because it is going this way, sexual intercourse may be a bit difficult. Here it is a little better. Okay. But here what you're doing, you're putting it right behind. So what can happen is this bladder becomes unsupported here. So here you can have more SUI as compared to here. That is why these things. If you understand the reason why these things happen, you will not forget. So remember this picture. Okay. So this is straight up. This is a better angle for sexual intercourse. So it has less problems with intercourse. This has more problems with intercourse because of the way it is tilted backwards. This has more problem with SUI. This has less problem with SUI post-op. Okay, so lower rates of post-op SUI. All right. So in those who are sexually active, what is preferred is abdominal sacrocolpopexy, but that does not mean that this is contraindicated. This is a common belief in candidates. They feel that this is contraindicated in sexually active. No. But if you're doing a vaginal procedure for any other reason, like if you decide to do a vaginal hysterectomy, it makes sense to do a SSF at the same time because it's a vaginal procedure rather than opening the abdomen again and doing the abdominal sacrocolpopexy, which should not be done. Okay, so what you need to know is this has a lower rate of dyspareunia. This has a lower rate of abdominal sacrocolpopexy has a lower rate of dyspareunia. It is preferred in sexually active. It also has a lower rate of post-op SUI. But you have also to look into whether the approach that is decided is vaginal or abdominal. So if it is vaginal hysterectomy, SSF makes more sense. Early recovery, because it is only vaginal, you're not opening the abdomen. So it is early recovery. Okay. Here, there is lower rate of recurrent wall prolapse because you're putting a permanent mesh, which is holding it up. Right? So this is what you need to understand as to why these things are the way they are. Okay. Then, robotic laparoscopic, again, laparoscopic would be more effective. I mean, robotic, there's not much evidence. Use of colpoclesis can be done for wall prolapse in old, frail women, okay, who do not wish to have sexual intercourse. Okay, in those women, you can consider your colpoclesis. This we have shown you. I have shown you already. This also. Okay, let's go through this quickly and we'll end up with this, I think. So, yeah, basically it is when you have symptoms of pain with any at the site of the bladder, okay, with lower urinary tract symptoms for more than 6 weeks. That is the American Association definition. But that is preferred as compared with the British because British says 6 months, which is a longer time, and so you take longer to treat. So it is preferred to consider 6 weeks so that you can start treatment earlier. Okay, so 6 weeks with symptoms suggestive of pain at that bladder site and your lower urinary tract symptoms. Okay. What do? You always do a bladder diary. In this case, so definitely you do a food diary because you want to see if there is any food item that is triggering the pain. You have to rule out urinary tract infections because here you have pain, which is a symptom of urinary infection. Okay, and even if the it's negative, urine dipstick is negative, it may be because of these organisms which may not show any urine positivity for leukocytes and all those things. Urine cytology, there may be malignancy, so you have to look at urine routine cytology to see if there are any malignant cells. Cystoscopy, if at all, is done. You have to check if there are these ulcers. If there are these ulcers present, it becomes interstitial cystitis. But cystoscopy is not something that you would do as an um, initial treatment. I mean, initial investigation. What you do is this, 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 and this. I mean, urine routine basically. Okay, so that is all, and then you can start the treatment or the management. If there is no response, then you can do a cystoscopy. If there is no response and you're suspecting a problem, and you can do urodynamics. If you're suspecting, say, if there are symptoms suggestive of OAB, then okay. Cystoscopy you will do in the first go if there is hematuria and all those indications for cystoscopy. If there are, then you will do in the first go. But if there is no hematuria, if there is no urine, no reason for you to suspect a bladder pathology, do not do cystoscopy in the first go. Okay. Then, yeah, this is what I wanted to show you. Basically, this is the most important part of the guideline. So as we have discussed, initial history, quality of life measures, urine dipstick, physical examination is always important, and frequency volume charts is bladder diary. If UTI treat, consider other causes and see if there is any history or urine showing any other causes. So here they have not mentioned cystoscopy, they have not mentioned urodynamics in the first box. So you can start, if this is there and you're suspecting bladder pain syndrome, you start the first line conservative measures, which is that is your lifestyle modification, analgesia, very important to keep in mind because something that we forget, it's bladder pain syndrome. So first line is analgesia, stress relief, dietary modification, exercise, physical therapy. So if that fails, you refer to secondary care. So here there is no MDT yet. Okay, no MDT. Secondary care, you can start amitriptyline and cimetidine. If you have both as options, option A is amitriptyline, option B is cimetidine. Which one will you choose? Which one would you choose? You would choose? Come on. Hello, anybody?
Usually we use analgesia and amitriptyline, right, doctor?
No. I mean, you have tried analgesia, stress relief, and now you are here. This arrow. You're here. You referred
Yes.
her to secondary care.
So
And that is what the question is saying. And your options are saying amitriptyline as well as cimetidine. So my question to you is, which one would you choose?
amitriptyline.
Yes. Amitriptyline because that is licensed, right? So it is a licensed drug. Okay. Now, if that treatment fails, then you come to your MDT. Okay. So here, next. Third line treatment after MDT. Okay. Is intravesical DMSO, heparin, botulinum, lidocaine, and chondroitin sulfate hyaluronic acid. Fourth line is neuromodulation, oral cyclosporin, etc. Fifth line is cystoscopy and hydrodistension. Okay. Now, and then the rest of the treatments which are not recommended are mentioned. But here you can get a question: which of the following is not recommended, or which of the following is recommended? And you can get all these in options and one procedure which is recommended. So you just have to go through these as well because they may come as options for you. Okay. So this is what it is. Conservative management, analgesia for 3 to 6 months, very important. Refer to secondary care if this doesn't work. Okay, so if that this is not working, then you go to this. Secondary care, you start amitriptyline in preference to cimetidine, as here it is written. Cimetidine is unlicensed, amitriptyline is licensed, but both are effective. MDT, if this doesn't work, then you go to MDT and the clinical psychologist. After that, you would consider your intravesical. Oh, this is intravesical treatment, which is not only botulinum, it is the other options. I think there is these options. I mean, all the options, not necessarily botulinum. Okay. And if that doesn't work, then neuromodulation and then cyclosporin and cystoscopy and surgery. Okay. Then, yeah. Actually, this is a last thing that I have, which I've already discussed with you, which I can just quickly go through and then we can finish there. Okay, so urodynamics indications we have gone through. I mean, NICE guidelines is what you need to remember. Okay. Frequency, These are the basically not urodynamic, but these are clinical symptoms. What is the definition? Is given in the strategy. Frequency is sorry, that is more than 8 times a day. Okay, not less than 8 times, more than 8 times a day, and more than once in the night. Okay, that would be nocturia. Polyuria is more than 3 liters. Polydipsia is more than 3 liters, where you drink more than 3 liters. Normal fluid intake would be 1.5 to 2 liters. Residual volume normal is less than 50. If it is more than 100, it is abnormal. Okay. Urethral pressure at rest is 90 centimeter, and urethral pressure postmenopausal is a little less, which is why you have SUI, 60 to 90 centimeter. Okay. Then these are important. This is very important, because you can get a question in the exam where they give you values and you have to interpret the urodynamics. So bladder capacity normal, that means the capacity that to which the bladder can fill before the patient feels like passing urine is 300 to 600 on an average. Okay. First desire is felt when the bladder becomes full to around, the bladder fills up 200 to 200 ml. That's when she feels her first desire. Strong desire to void is at 350 ml approximately. Retriever, this is what I was mentioning earlier. Retriever pressure should always be less than 15 at 500 ml of urine, and less than 10 for any value at 300 ml of urine. So what is this 300 and 500? That means if the bladder is filled to a volume less than 300, the retriever pressure should be lesser, 10 centimeter. Bladder fills a little more, 300 to 500. Retriever pressure should be may increase about 10, but it should be less than 15 centimeter. Okay, so on an average, you can remember that during filling, it should be less than 10 centimeter during filling, and between a little, it's close to voiding, it should be less than 15 centimeter. During voiding, bladder pressure should not rise above 70 centimeter, because it should be less than 70, because the very fact that the bladder has to exert more pressure means that there is some obstruction. Okay, should not go more than that. Normal Qmax or the flow rate is 20 to 36 ml per second. Usually, it should not be less than 15. Should not be less than 15. Okay, so it should be, that's how fast the urine flows. In other words, that's the normal peak flow rate. Leak should not be there on intra-abdominal pressure rise. Leak should not be there any phase in the filling phase. In any part of the filling phase. Okay, clear? This is important for us to know. Okay. So here you can see the first desire. Let's check. That's shown as FD on top. Can you see that? First desire. Okay, so first desire for filling. Okay, then you have the normal desire. This is how the bladder fills. This is increasing in volume. Okay, so you'll have initially the first desire, then you have, so the first desire is felt here. This is the filling, no? This is the filling here. It is around somewhere around 375. The first desire, which is I would say okay. A normal desire is there, and strong desire is here. This is the SD, which is strong desire. It is seen at here. So this is corresponding to around, I think this is 375. The earlier was a little lower. So this is 375, which is again normal. Okay, strong desire to void. Okay, then the maximum bladder capacity. That means you have filled the bladder, and here you have the maximum bladder. At this stage, the bladder will empty. So that is around, here it is 500, which is again fine. Okay, so these are the volumes that you could be asked about. Then this is normal. So first, to interpret, always check the P-det. P-det should always be less than 15 centimeter. Check if there is leak in any of the filling phase. Should not be there. There should not be any leak. Check if there is any leak corresponding to abdominal leak. Abdominal pressure rise. There should not be there. Okay, so that is what we had discussed earlier as well. Can you tell me what this is? Can you tell me what this is?
There is increase in the trousal pressure here. So this is trousal overactivity.
Very good. This is this is detrusor. You're right. This is labeled wrongly. OAB. This detrusor overactivity. This is, it's already mentioned. This is clear cut, straightforward. This is SUI. Okay, because abdominal pressure is rising and there is leak. You can see every point with the abdominal pressure rise, there is leak. Okay, considering this is P on top. Okay, this is SUI. What is this? Any idea?
Video urodynamic, doctor? Video urodynamic?
No, I mean, that is fine, but what is the condition?
It could be normal, this.
See, what you need to also see sometimes, which is not common, is this is the
Yeah.
flow, right? This is the flow of urine. Q. In other words, it is Q. Okay, so that's the flow of urine. I mean, whether there is any leak, you will be able to see a spike here on the flow chart.
Yeah.
And here you have to see this is the you should see ideally a peak. But here you can't see a peak and there is bladder increasing very high. It's gone more than 100. Can you see that? Pressure is more than 100. That means it is?
There's some resistance there.
It is? What is it?
Resistant. I mean, there is resistance.
Yeah. So it is called bladder outlet obstruction. Right? Because there is nothing flowing out.
Yeah.
Got it? So that is what it is. Now, this is hypotonia. Okay, similar thing. See, you will not have a very good flow here if either there is obstruction or the bladder is not contracting well. Can you see this? This is bladder hypotonia. Hardly any contraction in the bladder. Yeah. Right? So this is bladder hypotonia. Alright, so that was my last bit because I just wanted to cover the gist of urodynamics and the important ones. Of course, there are TOG articles, but it would take too long and it would be too tiring for everybody. So, any questions here you have? Anything that you want to clear?
Concept is clear.
Concept is clear?
Yeah. We cover all some materials.
Very good. Excellent. So, no questions? No questions? Then that's, I hope I've done a good job there. So, let me know if there are any questions. You can always put up on the group. You can put up feedback on the group as well. All right?
Yeah, okay. Thank you.
Yeah. Thank you. Good night. Good night, everyone.